So, now we talk about labor and delivery. Labor and delivery are physiological events with an enormous social impact. They are generally perceived as simple conditions and the population expects them to always go well. Unfortunately, the physiological event of giving birth can change in a few minutes into a dramatic condition because of complications. There are several characteristics that set our species apart from other mammals. Okay. Other birth differs, human birth differs from non-human primate birth in three different ways. The neonatal head and body generally pass through a series of rotations during birth in response to the close correspondence between neonatal head and shoulder dimensions and maternal pelvic dimensions. You can see the relations between the dimensions on the right. The neonate usually exits the birth canal in an occiput anterior position. Human birth occurs in a social context with others in attendance. That is, we have midwives in general. So, a short video was then shown, which said, during vaginal childbirth, the first stage of labor lasts about 12 to 19 hours and starts when your baby settles lower inner pelvis. In response, your cervix begins to efface or become thinner and dilate or widen. During this time, you may feel strong radial contractions occurring every 5 to 20 minutes and lower back pain and cramping that does not go away. You may see a brownish or reddish mucus discharge, which could be the mucus plug at your cervix opening falling out. Your water may break, which could either be a large gush of fluid or continuous dribble. If you experience any of these symptoms, contact your doctor. At the beginning of stage 2 of labor, which usually lasts from 20 minutes to 12 to 2 hours, your cervix is fully dilated to 10 centimeters and your baby's head has moved beyond the cervical opening of the birth canal. Your doctor or midwife will instruct you to push during contractions and rest in between them. In a normal delivery, your baby's head will rotate to face your back. During active labor, your uterus is divided into an active segment that contracts, pushing the baby downwards, and a flexible passive segment that remains relaxed, stretching to provide more room for the baby to pass through. When the top of your baby's head appears or crowns, your doctor may make a small cut, push your baby colon episiotomy to enlarge the vaginal opening. Then the doctor or midwife will give you instructions on how to push your baby out. As your baby's head passes through the birth canal, it molds into an elongated shape. An elongated shape will resolve itself in a few days as the skull bones shift back into place. After your baby's head exits the birth canal, his or her shoulders will rotate to allow them to pass through the birth canal. Your baby's shoulders are delivered one after the other in order to fit through your pelvis. Once the shoulders emerge, the rest of the baby will slide out easily. After your baby is born, his or her umbilical cord will be cut. In stage 3 of labor, which might last 5 to 30 minutes, mild contractions will help push the placenta out of the uterus. During this stage, you and your baby may start to accommodate through skin to skin contact and breastfeeding. End of the video. Labor. It's a sequential integrated set of changes within the myometrium, decidua and uterine cervix, resulting in effacement and dilation of the uterine cervix and passage of the fetus and its adnexa placenta through the birth canal. Pregnancy and labor can be divided in different stages. The first is a prelude to parturition. It's a period of quiescence where the uterus is at rest most of the time. Following, there are three stages of activation, stimulation and involution, which allow the physiological preparation for labor. Then there is the labor itself, and finally the recovery after delivery. So we have quiescence, activation, we have conception, quiescence, initiation of parturition, and we have the period of activation, onset of labor, and the period of stimulation, then delivery of conceptus, that we have involution, and finally fertility restored. So phase 0 is the functional quiescence. Phase 1 is the myometrial activation in response to urethotropins, like estrogen, which increases in this phase. We will have the increased expression of contraction-associated proteins together with an increase in gap junctions between myocytes. Phase 2 we have a stimulatory phase. The uterus is stimulated to contract by the action of the uterotonic agonists, mostly prostaglandins and oxytocin. Phase 3 it's the involution phase, occurs after delivery, and is the retraction of the uterus mediated by oxytocin. The onset of labor entails a molecular collaboration between the mother and the fetus. The big open question that remains is who starts the process. Whether it is the mother or the fetus remains unknown. In a certain moment of the pregnancy, usually around the 38 to 40 weeks, the syncytial trophoblasts in the intervillous space of the placenta start to release CRH, progesterone, and estrogens into the maternal and fetal blood. Cortisol passes through a maternal artery and enters the intervillous space, where it again stimulates the production of CRH by the syncytial trophoblasts. A fetal umbilical vein carries CRH into the fetal circulation, stimulating the fetal pituitary to synthesize corticotropin. So we have positive feedback, and drive fetal adrenal cortisol and Diaz synthesis. Cortisol and CRH stimulate the fetal lung to produce surfactant protein A, which moves from the amniotic fluid to the amnion, where it stimulates the production of cyclooxygenase 2 and the synthesis of inflammatory molecules like prostaglandin H2. This initiates an inflammatory process that, together with the normal cascade, will be at the base of the activation of the myometrial activity and the forceful contractions of the uterus. These molecules pass along the chorion and decidua and stimulate the underlying maternal myometrial cells to synthesize additional COX-2 and prostaglandin F2-alpha, mediating the uterine activity. During labor, myometrium is converted from a tissue with relatively low connectivity between individual myocytes into a tissue with extensive physical connections. Okay. Connections between myocytes during labor are formed and by release of prostaglandins and local release of calcium. This extensive physical and biochemical connectivity allows the depolarization in individual myocytes to be passed to neighboring cells and thus form extensive waves of depolarization and contraction over large areas of the uterus. This causes intermittent and strong increased intrauterine pressure and progressive distension of the cervix, leading to expulsion of the fetus. Interactions between actin and myosin determine myocyte contractility. After the myocyte depolarizes, there is an influx of extracellular calcium through calcium channels, and the release of calcium from intracellular stores, resulting in increased intracellular calcium, thereby promoting myosin-actin interactions and consequently stronger contractions. The activated myocytes produce prostaglandins, which act in a paracrine fashion to depolarize neighboring myocytes. This process leads to a wave of activity as more and more myocytes are recruited into the contraction. A critical aspect of myometrial activity at labor is the development of synchrony. Synchronous activity of myometrial cells results in powerful contractions needed to expel the fetus. If there is no synchrony, there will not be enough force to expel the fetus, and there will be a dynamic dystocia resulting in a non-physiological labor and delivery. The uterus lacks a pacemaker that regulates the contraction, although specialized pacemaker-like cells have recently been identified. Equally important are the intervening periods of relaxation, which permit blood flow to the fetus in between one contraction and the following one. After contraction, the myocytes relax and become refractory to further stimulation. To sum up, follow the graph below. Increased placental synthesis of CRH drives increased corticotropin and cortisol production in both mother and fetus. Increased cortisol stimulates further production of CRH, generating a positive feed-forward loop and a consequent exponential rise in CRH synthesis. The increased fetal cortisol leads to lung maturation, increased lung surfactant and phospholipid production. Cortisol and surfactant proteins activate inflammatory pathways in the amnion, leading to both cervical softening and myometrial activation. We need in parallel the softening of tissues and of the passive segment of the uterus, together with myometrial activation. The myometrial activation involves progesterone withdrawal and increased production of COX-2, which synthesizes prostaglandins and promotes contraction. Fetal growth and consequent uterine myometrial stretching combine with progesterone withdrawal to further promote uterine contractility. From slides, the placental clock. Production of CRH is an important factor in the timing of delivery. Women with an early rise in plasma CRH tend to deliver earlier, suggesting that production of CRH is an important factor in the timing of delivery. CRH has no direct inotropic action on the myometrium, but it upregulates the nitric oxide pathway. It enhances prostaglandins production. It potentiates the effects of oxytocin. Mechanisms of labor onset involve few cofactors. We have neural mechanisms, mechanical factors, humoral factors, endocrine factors. Mechanical factors are essential, and we can distinguish between uterine overdistension due to polyhydramnios or twin gestation, causing increased myometrium excitability, release of prostaglandins from uterine tissue, and activation of the Ferguson reflex. Faster reduction in uterine volume. For example, membrane rupture and leakage of fluid. Changes in the dimensions of the myometrial fibers can start the contractions. Volumetric reduction and increase in efficacy of contraction. Then you have uterine trauma. Neural activation. All what we have said till now will have a consequence on the adrenergic stimuli. This can increase myometrial contractility. From slides, changes in A2 and P local concentrations determine functional inversions of the myometrial tissue in response to adrenergic stimuli. P. Prostaglandin withdrawal causes increased adrenergic renaline catabolism and reduces beta-adrenergic. E2 favors noradrenaline release from the orthosympathetic fibers. This slide sums up the changes occurring in labor and delivery to increase myometrial activity. So we have estrogens increase, progesterone decreases, prostaglandins decrease and increase, oxytocin increases. So the increase in estrogen leads to reduced resting potential, increase calcium channels density, increase myometrial OT and alpha-adrenergic receptors, and reduce myometrial beta-adrenergic receptors. Progesterone decrease leads to increased resting potential, inhibits gap junction development, increased myometrial beta-adrenergic receptors. Oxytocin oxytocin increase leads to increases in irritability of myometrial cells, increased pulse conduction speed, increased availability of intracellular calcium. Overall, in conclusion, we can say that there are several actors that contribute to the onset of labor. The action of all actors is integrated and coordinated. The head of this orchestra and the starting point is the placenta CRH production. What occurs before this remains unknown. So labor is defined as uterine contractions that result in cervical effacement dilation with expulsion of the fetus. Delivery instead is defined as the mode of expulsion of the fetus and placenta. The onset of labor is not easily assessed clinically, and many inexperienced doctors will miss the true start of labor. We should proceed like follows. We have first initial examination, when we evaluate maternal vital signs, prenatal record for medical or obstetrical conditions, and fetal status. Then, second, we have to obtain a clinical diagnosis of onset of labor. So, we evaluate regular painful uterine contractions, typically occurring every 5-10 minutes, progressive cervical effacement, and dilation. We usually say a woman is in labor when the cervix is completely effaced and dilated to centimeter with regular uterine contractions. There can or not be the rupture of membranes with the discharge of liquid from the amnion together with the characteristics of the liquid, clear versus bloody. Then show the mix of bloody secretion with the mucus of the cervix. Third, evaluation of the cervical status. We evaluate the status of the membranes, cervical dilation and effacement, presentation and position of the fetus, and station the level of the presenting part. Laboratory tests are urine specimen, fourth laboratory tests, so urine specimen, complete blood count, ABO, RH typing, and antibody screening. The approach below allows us to identify true labor with respect to false labor. In true labor, we have contractions that occur at regular intervals. Then intervals gradually shorten, intensity gradually increases, discomfort is in the back and abdomen, cervix dilates, and discomfort is not stopped by sedation. In false labor, we have contractions occur at irregular intervals. The intervals remain long, intensity remains unchanged, discomfort is chiefly in the lower abdomen, cervix does not dilate, and discomfort usually is relieved by sedation. At the cervical level, we should be able to identify the following signs. Centralization. The cervix normally looks at the back of the vagina, while in labor it progressively aligns with the vaginal canal. Effacement, that is thinning and shortening of the cervix. And dilation of the cervix until we reach 10 centimeters of diameter. And then at evaluation, we should also evaluate the cervical position, consistency, and the station of the presenting part. Uterine contractions must be carefully evaluated, and they should be painful with an increase in pressure of more than 25 millimeters of mercury. Phasic contractions, around 3 contractions in 10 minutes. Repetitive, so maintenance of the contractions through time, and the interval between the contractions tend to decrease with time, while the length of the contraction itself remains constant. We now must consider the 3 P's of labor: power, uterine contractions, passenger, fetus, and passage, pelvis. Power is the force generated by the uterine musculature. It's characterized by intensity, frequency, and duration. It starts from the fundus of the uterus, spreading across and downwards. The contractions must be adequate to obtain proper cervical effacement and dilatation. These two processes occur parallel to one another. Passage of the fetus into the birth canal, that consists of the bony pelvis, composed of the sacrum, ilium, ischium, and pubis, and the resistance of the soft tissues and musculature of the pelvis. In the birth canal, we can distinguish 3 levels: pelvic inlet, mid-pelvis level, and the outlet. These 3 levels must be evaluated at the physical examination and during labor. because they are the points of rotation of the head of the fetus to allow for its passage through the canal. Amongst the soft tissues of the birth canal, we can distinguish the passive segment of the uterus, the more elastic segment including the cervix, the vagina and the perineum within its muscles. We have only one clinical way to evaluate the diameters of the pelvis in order to understand if vaginal delivery can be performed. We measure the anterior-posterior diameter from the pubic symphysis arch to the sacral promontory. This measure should be at least around 12-13 centimeters in order to be sure there is enough space for the passage of the fetus head. There are also many other measurements that are not considered clinically because they cannot be evaluated with simple examination. So, passenger is the third P. There are several fetal variables that can affect labor: lie, presentation, attitude, position, and station of the fetus. Lie is position of the long axis of the fetus relative to longitudinal axis of the uterus. It can be longitudinal, transverse. Longitudinal is a physiological one and appropriate for delivery. Transverse, either we try to reposition the fetus with certain maneuvers or we must perform a C-section. And oblique, same as transverse, so we try to reposition, otherwise we perform a C-section. Then the presentation, so the fetal part directly overlying the pelvic inlet. The fetus can be in vertex presentation with the head overlies when the head overlies the cervix. That is the physiological presentation. Shoulder presentation, which is not compatible with vaginal delivery, or breech presentation, where we might still be able to obtain vaginal birth in certain instances, although we normally prefer a C-section or to reposition the fetus in a vertex presentation by external maneuvers. Then attitude, degree of flexion extension of the fetal head. So we can have a vertex presentation, that is the physiological one, and is represented by a prominently flexed head. So you can touch the posterior occipital fontanelle. Then we can have bregma presentation, usually transient. The head in this position has a too large diameter for passage through the pelvic inlet, so the fetus must flex his head for delivery. Then we can have brow presentation, so head extension, usually transient. And then face presentation, so we have a full extension of the head. Then we have position. The relationship of a nominated site of the presenting part to the nominating location of the maternal pelvis. The indexes of the fetus are vertex, when the head is flexed, bregma, when it's less flexed, nose in extension, and chin, when there is face presentation. We then describe the relationship with the opposing part on the maternal pelvis. We have right or left, anterior or posterior. The most common and physiological fetal position is left anterior vertex position. Can also deliver a baby with a posterior position, but it typically will result in a longer and slightly more difficult delivery. Here you see the positions. During the pelvic examination, the mother we must also evaluate the station of the fetus, which is the degree of descent of the leading edge of the presenting part. It's typically measured as distance in centimeters between the leading bony edges of the fetus and the ischial spines. Ischial spines are set at the level 0. Below the ischial spine, the head is completely engaged in the birth canal, and the progression occurs until delivery. Above the ischial spines, the head is not completely engaged, and we still aren't sure we will obtain a vaginal delivery because the head is still not flexed and has not yet undergone the proper rotations for passage through the birth canal. When the fetus passes through the birth canal, we will have changes in the shape of the fetal head referred to as molding. It's due to compression of the head in the bony pelvis due to overlapping of the parietal bones, and the head becoming narrower and longer. There will be a complete resolution within a week following delivery. To sum up, in a normal labor we should have longitudinal lie, cephalic presentation, right or left accipit anterior position, attitude is one of the good flexion, the denominator is the occiput, vertex. We can describe three stages of labor. We have the interval between the onset of labor and full cervicus dilatation. Then the interval between the full cervical dilatation and the delivery of the infant. And third is the interval between the delivery of the infant and the delivery of the placenta. The whole course of labor should be monitored and reported on a partogram and compared to Friedman curves. This curve describes the course of a normal physiologic labor. Partogram form is a graphic representation of the labor curve against which a patient's progression in labor is plotted. The use of drugs, anesthesia, and oxytocin will also be reported on the form by the obstetrician. In this way, abnormal labor patterns can be identified and appropriate measures taken. There will be an initial latent phase lasting around 8 hours, followed by an active phase. This second phase is characterized by an acceleration of labor and contractions with increased dilatation of the cervix as represented by the curve of maximum slope, as you see here. We will then reach the complete dilatation of the cervix in 14 hours, or so in primiparous women, attempting first delivery. We then reach the second stage of labor. We refer to different Friedman curves for nulliparous and multiparous women. The phases of effacement, dilatation, and expulsion occur faster in multiparous women. The first stage is composed of two phases. You have a latent phase and an active phase. The latent phase is the point at which the woman perceives regular contractions, the period between the onset of labor and the point at which a change in the slope of the rate of dilatation is noted. It's a period of variable duration in which slow cervical dilatation occurs. We then have an active phase where the threshold is a cervical dilatation of 2 to 4 centimeters or more in the presence of regular uterine contractions. There is a faster rate of cervical dilatation that occurs to 1 centimeter per hour or more in a normal labor. So how do we manage labor? We have first, fluid and oral intake. Clear liquids are allowed, no solid fluids. 2, infection prophylaxis to prevent neonatal GBS infection, which is the agent of choice is intravenous penicillin. Then third, fetal heart rate monitoring. Then 4, cervical examination. Second stage of labor is can note an increase in bloody show. Cervix will be completely dilated. There will be a referred maternal desire to bear down with each contraction and a feeling of pressure on the rectum and a desire to defecate because of the pressure of the fetal head on that region. The mean duration is 50 minutes for nulliparous women, while 20 minutes for multiparous ones. Then cardinal movements are spontaneous fetal movements occurring in the second stage. They can be rotation is fundamental to switch the head from a transverse axis to an anteroposterior one, allowing to pass through the diameter of the birth canal between pubic bone and lower portion of sacrum, which at this level is no more than 10.5-11 centimeters. Further descent and reaching of the inferior level of the birth canal with an initial extension of the head because the occiput will act as a pivot on the pubic bone. Then, at the level of the superior pelvic inlet, this allows to achieve the best diameter for progression through the birth canal with an obliquely positioned head. Delivery delivery of the anterior shoulder under the pubis. As the head comes out, we have the movement of restitution, which is an external rotation from anteroposterior diameter back to transverse head diameter, as it was before entering the birth canal. Then we have delivery of the anterior shoulder under the pubis by stretching the head a little bit downwards. Then after the passage of both shoulders, the rest slides through easily. Engagement. So we have engagement. One occurs in late pregnancy or at the onset of labor. It occurs when the head is at the superior level of the birth canal, starting to move towards the ischial spines. The mode of entry depends on the pelvic type, and the most common position, over 70% of cases, is the occiput transverse position. Then we have flexion. The shorter suboccipito-bregmatic diameter is substituted for the longer occipito-frontal diameter. There will be flexion and engagement with descent into the birth canal. Then we have an internal rotation to reach the mid-level of the birth canal and the ischial spines. Vertex usually rotates to the transverse. It must next rotate anteriorly or posteriorly to pass, achieving an anterior-posterior diameter. Normally the rotation is directed anteriorly. Fourth extension. As the head passes through the birth canal, when it reaches the vulvar plane, we will have the crowning of the head. Upon crowning, the fetal head extends. It will distend the perineum, and we will wait a moment to let the muscles accommodate the distension. The suboccipital region of the head lies beneath the pubic symphysis and acts as a pivot for extension. Then we have restitution. After the head is delivered, it rotates to its original position. Next, the shoulders descend and rotate anteroposteriorly, and the baby is delivered. Episiotomy. It's a cut performed by the doctor or midwife to allow an easier delivery of the fetal head. It's a very debated practice, generally preferred by doctors so to achieve a rapid delivery and then suture when the cut was performed. Cutting line is established by the doctor, and so they can suture it back after delivery. Midwives typically prefer a longer delivery so to allow the distension of the perineum and its muscles without an episiotomy. Unfortunately, though, almost always you will have a laceration of the vagina and probably of the underlying muscles, which will remain covered because you have not performed the cut of the muscles you have not performed the cut of the mucosa as in an episiotomy. You will not know if you had a laceration of the muscles. Typically performed if the fetus is very large, or to precipitate delivery, or if instrumental delivery is indicated, and to avoid fetal maternal distress. Delivery is the main cause of late prolapse of the uterus, bladder, or rectum because of trauma in the perineum region that was not repaired. It's not a complication occurring to all women. There are also many other risk factors for the development of late prolapse. It's important to prevent this complication, to respect the integrity of the perineum and of its muscles supporting the bladder, rectum, and uterus. We must also, for this reason, avoid any maneuvers causing a pushing force on these structures, such as pushes on the fundus of the uterus to expel the baby. We should also avoid very long delivery, instrumental delivery like vacuum extraction or forceps. Then, third stage, we have a separation of the placenta from the uterus, a descent and expulsion of the placenta, inspection and repair of the cervix, vagina, and perineum, and prevention of excessive postpartum bleeding. Any period up to 30 minutes is considered to be within normal limits. We usually wait up to 30-60 minutes before intervening to expel the placenta. Hemostasis. Retraction of the oblique uterine muscle fibers in the upper segment through which the tortuous blood vessels intertwine, together with the resultant thickening of the muscle, exert pressure on the vessels, acting as a clamp to control bleeding. If you were not to have such mechanism, whether because of a soft non-retracted uterus or an atonic non-contracting one, you could have a very large and dangerous hemorrhage. The postpartum bleeding can also be massive, filling with liters of blood in few seconds. This is how a complete physiological event as labor and delivery can change into a dramatic and critical situation. Then we have something not discussed in class. So, separation of the placenta, fresh show of blood from the vagina, the umbilical cord lengthens outside the vagina, the fundus of the uterus rises up, the uterus becomes firm and globular. When these signs appear, it's safe to place traction on the cord with a counter pressure between the symphysis and fundus. Puerperium is the period following the delivery of the baby and placenta to 6 weeks postpartum. The immediate postpartum period within the first hour of delivery is a critical time. Uterine blood loss must be monitored closely. Laceration of the birth canal. We have a first degree laceration, second degree laceration with involvement of the bulbocavernous muscle and the superficial transverse perineal muscle, third degree laceration with an internal anal sphincter involvement, and fourth degree laceration. Now in this third degree laceration we have internal and external anal sphincter involvement, and in the fourth degree laceration we have internal external anal sphincter involvement and also rectal mucosa.